Welcome to this Master Instruction course on this solving refractive conundrums in cataract surgery in reference to IOL grand round. Many times when the patient is in front of you, it's very confusing and very difficult to understand what kind of management that we want to do to meet with this performance. But I think before we get into the details, I think it's important to recognize that there is a need to continuously refine our performance, not only on the table, but also in the long term, so that the outcome is predictable and better, immediate, as well as in the long-term need. And ultimate goal of all of us is to make patient happy. And cataract surgery being now as a refractive surgery is one of the important tool or a step to make this patient happy. So with all the understanding that you're going to listen from our experts here, we'll be able to make the and the cataract surgery in such a way that the patient will be happy, and we all will be able to achieve our goal. So with that in mind, I think I'm glad to tell you that we have a very experienced and very talented faculty, and we have selected the topics that are very, very important and really are a bother to us and to the patient in different scenarios. So we begin with Dr. Lajja. Lajja, please take over.
Yes. Hello, everyone. I hope my screen is visible and I'm audible. Can I have a feedback? Am I audible?
Yes, Lajja. Yes, you can.
Yes, ma'am. Yeah. So today I will be talking about toric IOLs in special situations, because as we all know, for our routine cataract surgery patients, the use of
your screen is not visible. You have to share your presentation on the share.
Yeah. Share. Yes, 1 minute, sir.
Share is on the right side.
Yes.
Right. Right. Got it.
Yeah. So, like I said, for our routine cataract surgery patients, we all use toric lenses to treat significant and regular corneal astigmatism. It's become more of a norm. And yet we come across situations where we are not very certain whether using the toric lens would be the right choice for this particular patient or not. And hence, in today's talk, I'm going to share with you some such unique experiences that we have learned some very important lessons from. The first patient I share with you is somebody who had a compromised cornea. A young female who came to us with a complaint of blurred vision and a history of being a myope all her life. She had actually undergone an RK surgery many years ago, again gone back to using glasses and not very happy about that. So when we evaluated her and saw that she had a significant and operable cataract along with these 8 radial keratotomy marks, when we evaluated her preoperatively, we were really not surprised to see this flat cornea, nor were we surprised by the fact that there was a significant corneal astigmatism. But we expected this astigmatism to be irregular given that she had an RK surgery done. So to our pleasant surprise, when we performed her topography, and as you can see in the black circle, the cornea within this mesopic pupillary area is actually a completely regular astigmatism. So this is actually an ideal candidate for a toric lens, and yet we hesitated. Because as we know, the success of a toric lens depends not only on our precision of magnitude and axis determination, but also on precise spherical equivalent power calculation. And both of these would be a challenge in somebody who has an RK surgery done. But again, very fortunately, we live in an era where we have access to some of these very advanced new generation calculation formulas provided by some of our brilliant peers, which help us land as close to emmetropia as possible. And so with all this due diligence done, we suggested the option of toric lens to this patient, making sure she understood that despite our best efforts, she may have to sometimes use refractive error if we actually landed with some. She opted for a toric lens implantation, and as you can see, a beautiful image of toric lens on its intended axis. But what was even more beautiful was the patient's response. She told us that she couldn't remember the last time she had seen so well without glasses ever before. So a very important lesson learned from this happy experience was that even if somebody has a compromised cornea, let's say by a corneal opacity or a prior RK or a LASIK surgery, if the cornea within the mesopic pupillary area is a regular astigmatism, then we can consider implanting a toric lens. However, in such cases, we must pay a lot of attention to the formulation aspect in terms of acquiring accurate data using the right calculation formula, such that we land in a situation where we want a refractive outcome to be optimal for the patient. The second patient I share with you is somebody who had a compromised capsular bag. A young man who came to us with a history of injury about 2 to 3 weeks ago, and as you can see the cataract in the center. But what you will now see is that there is a pre-existent PC defect already. So we were more concerned with how we were going to safely remove this cataract and implant the lens in the bag or not. And so when we saw that he had also regular corneal astigmatism, we were not certain whether advising a toric lens would be the right thing to do or not. But then we saw that the axis of implantation in this particular case would actually be perpendicular to the line of axis of the PC defect. So we were hopeful. We explained this possibility to the patient, ensuring that he understood that only if we thought that the capsular support was adequate will we put the toric lens, otherwise a monofocal lens. He agreed to keep toric lens as a standby option, and fortunately, he also agreed to femtosecond laser-assisted cataract surgery, which allowed us to employ the concentric ring pattern for lens division, which we could then subsequently peel off in a very sequential, controlled manner using low aspiration parameters that you can see on the right-hand side of the box, low bottle height, low aspiration flow rate, lower vacuum, such that the pre-existent PC defect did not extend any further, nor was there any vitreous prolapse. Following a safe removal of the cataract from the bag, using high viscosity cohesive viscoelastic, and I cannot emphasize enough how important it is to use a cohesive viscoelastic agent, the toric IOL was manipulated gently on its intended axis. It's the cohesive viscoelastic that can actually be removed as a bolus and will not be retained in pockets inside the capsular bag, causing any postoperative rotation. And as always, we would end this surgery with injection triamcinolone to make sure that there are no vitreous strands left behind undetected. Following this surgery, as you can see here, a very stable toric lens in the bag on its intended axis. And the very important lesson learned from this very challenging scenario was that in select situations where there is a PCR, but if we can convert this into a strong continuous PCCC margin, and if the rest of the capsular bag support is adequate, we can consider a toric lens implantation. But we must always make sure that we are paying a lot of attention to the surgical aspect of these kind of eyes in terms of using closed chamber technique, appropriate aspiration parameters, using the right viscoelastic devices. But choosing the right type of toric lens is also very important. When I say right type, what I mean is we want the lens to unfold very gently, gradually, such that there is enough time and stability inside the eye to manipulate. We don't want the lens to open in a jerky manner. And we also want the lens design and material to be such that it will remain exactly where we leave it behind without any chance of postoperative rotation. So choosing the right type of parameters and right type of lens would be very important for a successful outcome in such scenarios. The third patient I share with you is somebody who had another eye refractive outcome that was compromised. A middle-aged female who came to us with a complaint of blurred vision in both her eyes despite one eye being operated previously. And she was not using any glasses whatsoever, but on refraction, we found that her operated eye actually had significant residual refractive error. However, it was this notch in the pupillary area which made me a little suspicious, and sure enough, on dilatation, we find that there was a PCR. The lens was in the sulcus, but more importantly, it was a toric lens. So what we have here is a decentered toric lens in the sulcus causing a significant residual refractive error. So when we saw the other eye also having corneal astigmatism that was significant, we were faced with this dilemma. Should we now advise a monofocal lens and have her use glasses for both her eyes? Or should we implant a toric lens, try to reach emmetropia, and try to reduce her dependence on glasses binocularly? The patient opted for a toric lens implantation, and following an uneventful surgery, we were happy with the refractive outcome of this eye, but the patient was extremely happy with her binocular unaided performance. So a very important lesson learned from such a scenario is that even if one eye has a significant residual refractive error, we must try to aim at emmetropia and use a toric lens if we need to, and try to give a kind of outcome where binocularly the patient is not so dependent on glasses all the time throughout their day. Another very important lesson is that a toric lens is only meant to be implanted in the capsular bag in a very well-centered manner. So if there is a PCR and if we cannot for some reason implant the lens in the bag, then we must abort that plan, implant a monofocal lens instead. So finally, to summarize, I would say that if an eye has a significant and a regular corneal astigmatism that can be corrected with a toric lens, and if we can ensure precision at every level, right from evaluation to formulation to implantation, then this particular IOL technology, the toric lenses are extremely rewarding and satisfying even in these kind of compromised eyes. Thank you so much.
Lajja, that was an excellent presentation. I have a question for our friends who are listening here. What is the age or lower power of toric that you would suggest? I mean, the beginners are taking the toric in their practice and they want to master it. So what's your advice to them?
The advice would be that if the patient's age is around 5 to 6 years, and if they have a regular significant, and when I say significant, I mean more than 1.5 diopters of corneal astigmatism, it is by that age the astigmatism actually stabilizes. So if we can make sure that the data that we have acquired, actually that is very important, to make sure that we have accurate data. We also need to make sure that it is a regular corneal astigmatism. But if we can ensure both of these, then even in pediatric patients of 6 years to onwards, we have implanted a series of patients who have toric lenses. And this is the age where if we can achieve emmetropia for them, it is an amblyopigenic age. And if we can provide good vision, they would significantly benefit. So even in the patients who are aging from 6 onwards and have significant corneal astigmatism, we must go ahead and implant a toric lens.
Just to add to that, I think what you also meant was how much do you use as a cutoff for beginners to start using toric IOLs? And I think for people who are starting or getting into toric IOLs, first choose cases which are likely to give you good outcomes, which the patient is going to appreciate. So if you start with your journey of toric IOLs with T2 correcting 0.5 or so, you won't be able to assess how you're going, and the patient is not going to see that wow factor. So start with anything 1 and above. Slowly, as you start getting experience, there is no limit to the number of astigmatism that you can correct. So Dr. Lajja would concur that she uses the formula, the Barrett's formula, to calculate the measurements of each patient, whether it requires a toric or not. So don't rely on your judgment whether this K1, K2 difference is more than 1, so you choose it. If it's less than 1, you don't choose, because the role of with the rule, against the rule, posterior cornea, everything plays a part. So calculate for each eye, because you'll be surprised as to how many torics that we are missing out on.
And how low? I mean, I'm scared of putting T2 because I'm not sure in my control and outcome of this. So how do I achieve that control in the preoperative? Briefly, could you explain us what is the most important thing that will help us to put a low-powered toric IOL?
So first of
for
all,
example, which one would you recommend, and so on?
Yeah, so the optical keratometers that are giving us very high accuracy in our keratometry values, and also those we can actually calculate or incorporate an algorithm for the posterior corneal astigmatism. The whole point being that we need to know the total corneal astigmatism. And when I say total corneal astigmatism, I mean anterior, posterior, as well as our surgically induced astigmatism. So if we are very accurate in our total corneal astigmatism evaluation, then even using a T2 can lead to very satisfying and rewarding results. And also using the right kind of calculation formulas. Fortunately, we have access to all these very new generation formulas online. So using the instruments that will allow us to have the very accurate data of anterior and posterior corneal astigmatism would help us use even T2 very successfully.
Thank you. Any other questions or comments? I think wonderful, Lajja. Thank you. I think stay there and we will need you in the discussion as we go ahead. I invite now Dr. Samresh Srivastava for his presentation.
Thanks a lot, Dr. Lajja. You set up the ground for my talk, and you brought out some points very nicely. So I'm going to be discussing how to and what to do and what not to do in post-refractive surgery eyes. And these eyes are special. These eyes are very unique because there's a lot of problems since the corneal profile has been changed. The corneal shape has been changed. There is changes in the aberrations. There is changes in the curvature, leading to changes in the asphericity. All this mounts down to finally calculating the right IOL power. And if you have a wrong IOL power, you're going to land up with unhappy patients. But most importantly, sometimes these patients will end up with other problems, like optical phenomenon of glare and halos and dry eyes, just because their corneas are not in the perfect shape, particularly with older generation LASIKs. So just to give you a brief on what a normal cornea is like, a normal cornea, a pristine cornea has positive spherical aberrations, which essentially means that when rays of light fall onto the macula, the central rays of light, as you see over here, tend to bend a little less than the peripheral rays of light. So notice the angle for periphery is a little more and the central is a little less. And this is a classical positive spherical aberration, which is a natural mechanism. So when you do a myopic LASIK, you tend to flatten the cornea. So when you flatten the cornea, your central becomes flatter compared to the periphery, causing an increase in positive spherical aberrations in a normal scenario. So again, if you look at a simple ray diagram, if you notice the peripheral rays of light that now focus tend to deviate more as compared to more central rays or more rays in the visual axis. And this causes increase in positive spherical aberrations, thereby increasing the glare. Now, if these patients are to come to you for a cataract surgery, I think the most intelligent thing one could do in the simplest of ways is to put an IOL which negates it inside the eye, or a negative asphericity IOL. But different companies have different options that are available. Like Alcon comes with a minus 0.15 asphericity, and AMO, I think Johnson & Johnson is a minus 0.3. So I think in this case, an IOL sometimes with more asphericity, more negative asphericity, will try and compensate for the corneal problem, which has been done by LASIK. Hyperopic LASIK is the exact opposite of myopic LASIK. So now you're ablating the mid-periphery. So you are bumping up the central cornea, making it steeper, and you're landing up with negative spherical aberrations, which essentially simply means that your central rays of light are now going to bend more than peripheral rays of light. So your angle for the center is going to be more than the angle for the periphery, and thereby the exact opposite of myopic LASIK. So you need an opposite lens. You need a negative aspheric lens, which is difficult, or a zero spherical aberration lens, which I think some companies, although I'm not sure if Bausch & Lomb still has zero spherical lens, but Bausch & Lomb at some point in time had a zero spherical aberration lens, or an aberration neutral lens, which would be the right choice of lens in this eye. The other big problem is actually measuring the true corneal curvature. Like Dr. Lajja said, it's very difficult because most topographies, our placidos and our manual keratometries measure the anterior cornea. But what's the problem is that when we ablate, we sort of clear up the central cornea. If you notice over here, the central cornea flattens out. So the anterior keratometry readings change, but the posterior keratometry readings still remain the same. If you were to use an older generation placido, you do not understand this relationship between anterior and posterior, and the placido and the formulas would assume that the posterior cornea follows the anterior cornea, which is not the case. So measuring a true corneal curvature by using any of the mechanisms of using a Scheimpflug imaging with a pentacam or a cirrus, or using OCTs, which are now being increasingly validated and proved, is a good idea to measure the actual K reading, which incorporates the posterior cornea. Needless to say, optical biometry gives us far more value because it helps us in finding out the effective lens position, or the ELP, which has been so much talked about. But what is this ELP? Suppose you have a hyperopic eye or a smaller cornea, your actual lens position will be somewhere here. When you do a myopic LASIK, if you don't use the right biometry, you are going to underestimate or overestimate the actual anterior corneal depth, thereby leading to a wrong calculation. So a good biometry is very important. When you have that data, you should use that data wisely. So what I would suggest, and what we normally would do, all of us would use an ASCRS online calculator, which so generously has been given to all of us for free. And it incorporates a lot of higher generation formulas. This is how it looks. There's options for myopia, hyperopia, and prior RK done. And once you choose that, you fill up all the data, and the machine tells you what IOL selection is to be done based on what formula, which is visible over here. It also gives you 3 ranges. It gives you average, minimum, and maximum. The Barrett-Truque formula is also available on the APS-CRS website. Thanks to Dr. Graham Barrett. It's available for free for all of us to access. And once you put all the readings that you pick up from your topographies, the machine will give you a calculation. When you compared in our clinical setting, in our hospital, and I think the group published it in 2020, we compared the IOL calculation methods, these formulas, after LASIK and RK in patients where we had no prior refractive data. The patients walked into our clinic and were operated many years ago elsewhere. So the aim for this study was to compare IOL prediction error and refractive prediction error when we use the four most commonly used formulas, which are available on the Ascrs calculator for free. And this is what we found. We found that the least prediction error in terms of the IOL prediction error was with the Bayes-Kluge formula and the Shammas' formula. And this was statistically significant. We also found that the refractive prediction was also significantly better with the Barrett-Truke and the Shammas formula for LASIK patients. So we concluded that all formulas, though perform very well for LASIK eyes, Barrett-Truke and Shammas are the go-to formulas. When we looked at prior RK, because a lot of RK flows in for cataract now, so considering a lot of RK was done a couple of decades back, we found out that the most important formulas were Atlas 1 and Barrett-Truke, both for IOL prediction and for refractive prediction. And we concluded that most of the eyes were within plus minus 1 diopter, which is a pretty good outcome for an eye with prior RK done. So we concluded, although all formulas do well with RK, the Barrett-Truke and the Atlas formulas do much more better than the other eyes. But the most important recommendation that we also got out of this study was that when you look at all these values from ASCRS calculator of average, maximum, and minimum, choose the minimum IOL power for LASIK and choose the average IOL power for RK to hit the bang on target. And that would give you a good outcome. Needless to say, one needs to be very, very careful of looking at corneal irregularity and spherical aberrations. And one also needs to look at the patient's mesopic pupil size. So I always encourage you to do investigations in a dim lighting condition, because in these eyes, as the pupil goes dimmer and darker and the pupil opens up, their visual quality is significantly deteriorated for no fault of the cataract surgery that's going to happen. But the RK or the refractive surgery couldn't contribute to it. I would counsel all these patients about refractive residual errors, despite the best biometries and calculations, and most definitely in most patients, barring aside a few, I would avoid multifocal IOL and obviously counsel them for visual problems. So just one case scenario, just like Dr. Lajja showed, a 55-year-old lady who had LASIK operated not very long ago, came to us with the decreased vision. So not a long ago LASIK means a good LASIK because it's a spheric profile. Her keratometries are within a respectable limit and she has a diopter and a half of astigmatism. But the best part is that she's a regular astigmatism in the pupillary area, which is the area of interest, because every else other cornea doesn't matter, because the light's not going through that cornea, but the visual axis. The aberration profile was very good. Like I said, a recently done LASIK will have an aspheric profile, so the cornea was in a quite good shape. When we calculated the IOL power using the IOL formulas available here, and we tended to go with the Barrett-Truke, which is our go-to formula in any case for most of the surgeries. And we implanted a toric IOL in this patient. And needless to say, because everything fell into place, this was a good patient outcome, and we had an uncorrected distance visual acuity of 6/9, which generally would happen if you use the right formula as well. So the take-home message from this case was that you can do a toric IOL, but please be aware that your visual axis or your pupillary area is regular in nature. What's happening in the periphery shouldn't really matter in the from the optical point of view. But please do counsel these patients that despite it all, you can have a refractive surprise. Be very aware and teach your staff to look at the raw data. So if you have a bad topography, you're going to have bad K readings, and bad K readings will translate to a lot of bad generally for the patient. So this is the same patient pre-operatively when we were doing a biometry, and this were the Mayas, and our optometrists are trained to pick up these red flags. Once we put a topical lubricating eye drop, we tend to wait for 10 minutes for the tear film to stabilize, because you can have erroneous readings immediately after a lubricant. So we waited. And then after 10 minutes, we repeated the biometry and the topography. And notice now we are getting very good K readings over here. And the aberration profile of the patient that was there before with the dry eye versus a patient post for 10 minutes of stabilization with the lubricant is significantly low, which essentially means your tear film was the culprit here. But the biggest problem was that your keratometry is changed. And if your keratometry is changed, what's going to happen is your biometry is going to change and your IOL power calculation formulas are going to change, and you're going to land up with a refractive surprise, which was for no fault of the LASIK, but a fault of the dry eye. So in such patients where you have extensive dry eyes, I would strongly recommend some sort of tear substitution. If you see them and stabilize their tear film before you do a pre-op, and then you counsel them. Like I said, just to end my slides, to show you the same patient, this is the biometry done with the dry cornea, and this is the biometry done post 10 minutes of stabilization. And notice how we jumped a diopter. So if you pay attention to these small nuances and you pay attention to these small things, use the right biometry, use the right formula, and watch out for red flags. Most likely than not, you will achieve a very good outcome in these patients. Thank you.
Thank you, Samresh. You mentioned that you take the least recommended power for post-LASIK patients and an average for the post-RK. Why is that? Please explain that. What happens? You know?
I think that was a great observation at my end also when I went through the paper. Is that when we looked at the prediction errors, we found that the patients where we've chosen the least. I mean, I really cannot tell you the cause, but the patients for LASIK where we chose the least power, we were bang on or close to target. And for our case, I think again because of unpredictability of the K readings, the average worked out more favorable for us.
Because generally people end up in hypermetropic side post-LASIK patients because the false measurement of the anterior chamber depth.
That's also
so. Is that what you would end up if you do not take minimum? Is that what?
I guess so. I think so.
You also alluded to this tear film and the thing. How much is the difference if you do not take care? I mean, is it a big thing? Should we really be very, very particular about the tear film before we measure the keratometry and all the other things?
I think that's a great point. And I think of all the things, if there is one take-home point from my talk, it's that the tear film is the most important refractive surface of the eye. So if your tear film is bad and you've done your calculations based on the first optical element being bad, then your outcome is not going to be favorable in terms of the biometry, let alone the discomfort and post-operative problems if you have a severe dry eye. So getting the tear film to get sorted out is very important. On the other hand, over-treating the tear film by putting a drop and immediately doing a keratometry reading or a biometry may also give you an erroneous reading. So you would want to wait for the tear film to stabilize before you do that.
So how long would you wait?
So I said for 10 minutes, 10 to 15 minutes after putting a lubricating eye drop would be a reasonable end point.
And how do I know that this patient tear film is not that good? It's not dry, but what's a simple basic examination that you will share? Because it's very important.
Yeah, so I think for most of the clinicians who are doing their own biometries, it's pretty evident that when you do your manual keratometries and you ask the patient to fixate, the tear film tends to break up and the Mayas tend to distort. Doing a very big dry eye workup for all patients is not practical in our clinics, but at least if the optometrists are trained or if the surgeon primarily does the keratometry to see how quick the first dry spot appears, it gives a very important clue and a very practical clue. So if your biometries are jumping or your keratometries are jumping, be very aware that these are not the patients you want to do advanced technology IOLs before stabilizing the tear film.
Okay. Any other comments, Lajja, Shail?
Generally, for a lot of these patients who have had a prior LASIK or a prior refractive surgery done, what we tend to also do is that make sure that they are put on lubricating drops at least 3 to 4 days prior to surgery, because any of that dry surface can also cause a lot of stray light and glare and halos to the patient, even with monofocal type of lenses. So we have seen that, stabilizing, as you mentioned, Samresh, stabilizing the tear film is extremely important to the quality outcome of their visual performance following surgery.
Just a small point, you must use a low viscosity lubricant, like a polyethylene glycol or cystine or something that is low in viscosity, because it doesn't cause visual disturbances. And gels in the night before surgery is not a great idea, or before pre-op testing is not a good idea.
Absolutely.
Okay. So if there is no other question, I would go with my presentation here. We do receive research grant support from Alcon, but has no relevance in this talk, and recognize the contribution of our colleagues at Raghudeep Eye Hospital, Ahmedabad and Jaipur. And time has now come to customize, as we know, for quite some time, particularly for presbyopia solution. And I'm going to share some real life scenario, but before I do that, we understand that there are various options we have, and monovision strategy has been there for a long time, even before multifocals and other technology came in, and it works well. And people do contact lens trial, whether they would suit in, and what is that mini monovision or large has been a strategy, but it's never caught on. I do know that there are good surgeons who continue doing it, but generally speaking, because of the asymmetrical visual performance, It's never caught on, and people have relied on a symmetrical both eyes, generally speaking, and that's how the traditional multifocals came in. Then there was some improvement on some distance on the low ads, and then the trifocals came, and the trifocals really have changed our approach to the managing these patients' need and their lifestyle. There are now extended depth of focus lenses, which is a kind of a modified monofocal lens, but has an added advantage of depth of focus, giving intermediate and some of reading vision. And accommodatives and small aperture IOLs are still there and it's trying to establish their value with time. The popular multifocal option so far until recent times was the traditional with +3 and nearby addition. Typicals are Restore, Techniques, Atlisa, etc. And then the low ads with Oculentis, Symphony, and 2.5 Restore. And then came the game changer, trifocals. And now we have even a further improvement on these trifocals as we progress. The trifocals, for your just reminding, it's a 2 focus distance and near 30 to 40 centimeter. And it works out quite well for some people who are using that distance for whatever activity they're doing, but it was realized later on that intermediate vision at 50 or 60 centimeter is more important in the users. For many people who are really doing different activities for their livelihood or for leisure activities, that prolonged distance, intermediate distance, and that term intermediate distance was really never existed several years ago. So that not only the reading vision, that 30 or so distance, but the 60, 70 intermediate was very important. And having understood that, the industry came up with the right solutions in trifocals, giving not only the near focus at 40 centimeter, but also intermediate. And with the optical principles involved in the architecture and fabrication of this IOL, it has to end up at 80 centimeter in intermediate distance. And that worked very well for most of the people, but we realized that 80 centimeter could be too far. In reality, the intermediate distance with the average height and the arm length would be little less than 80 centimeters. So PanOptics, with its unique technology of making this different distances, came up with a very smart idea of reducing intermediate to 60 centimeters. So it brought down nearer from 80 to 60 centimeter. And because of that larger central disc involved, a larger area of a flat central distance vision disc, and the technology, the light passing and going to the retina is quite high, probably higher, almost higher than others, but other Atlisa also has a good penetration. And at 3 millimeter, it's very good. So I think if you really want to now go for happy customization, and as we heard in the previous presentation, obviously fundamental is to understand the eye, understand the patient, and have an appropriate solution in terms of intraocular lens. So I'm going to share 1, 2, or 3 cases for you. And this is a very, very typical patients of a cataract population. Any patient who is elderly, not very active, say 70 years nowadays or plus, and with the age, many of them become forgetful. And this lady was one of those, and really had to struggle to get the glasses, find where the glasses been put. So she came to us with the bilateral cataracts. She was active otherwise, not going outdoors or doing any fitness activities, but fairly active in watching TV and reading and everything. So, but she wanted to get rid of glasses. So her ocular profile, and we will come to that in the last talk also, what are the things that we need to look for, was quite okay for receiving multifocals. And we decided, now that we had the PanOptics available, we used the PanOptics, which used the adequate light for this aging retina. And we also explained to her that in a prolonged reading, she would need extra light, not only because of the age, but also with some loss of contrast sensitivity with these trifocals, including PanOptics. So she had the binocular PanOptics put in their eye, and now She is very happy and doesn't need to remember where she has put the glasses on, and she's able to function even if she's indoor, all kinds of activity. So what is it that we learned? That any age, 80 years or 80 years plus nowadays, or any age, is not a bar for multifocal lenses, which includes trifocals, of course. And if the eye is suitable for it, we should consider it and we should offer it. Maybe they will not go for it for whatever reasons, money or whatever mindset, but we should forthrightly suggest to them that this is one more option. And at this age, you will be able to enjoy this new lifestyle and you may love it. This is another extreme age, young age, and we get so many young patients, and we all do get many age. This is a very active person. He could be engineer, banker, but this guy was an engineer, and not only blurred vision, but the glare was a real nuisance to him because he drives outside, and he had a motorcycle, and then glare was really a bother to him. And he was myopic. And remember, young age and myopic. Myopic up to -1, 2, 3 really are eyes which we need to be very attentive because they've enjoyed that myopic benefit of reading vision. And as Lajja said, it's a birthright, I think. So high myopia, it's okay, but this kind of myopia, which is not very high, not 0.5 or 1, but 1 plus to -3, -4 are an issue. So we need to keep in mind and all this. And luckily for him, there were no red flags on contraindicating the optical difficulties of multifocal, and he was suitable for multifocal lens. Now, being young, we went one eye, and we wanted to assess how we will do with the other eye, and we told him also, and we were ready to change the strategy in case that doesn't work, because young people and they are sometimes we think they are unreasonable in their demands, like the post-refractive patients. So we had to keep in mind his work profile and his personal preference. And many of these have advised them against, and that's not uncommon, particularly with a doctor's reference or doctor's relatives. They send the patient to us that, please ask the Dr. Vasavada not to put multifocal without any knowledge. So this is unfortunately this reality. But the guy said, I want to get rid of the glasses, and I need to see without glasses, if possible, all of the things that I want to do. So we tested in first eye with low ad restore at that time. And we decided to do that because obviously we all need good distance quality vision, and restore low ad had that, and also had additional intermediate vision. And the glare and the dysphotopsia was minimal. And we told him that. So we decided to do that. And he had a good distance vision and reasonable good intermediate vision, but he struggled to read in spite of telling him that he will need reading glasses. So we were just watching how we would behave. But he did suggest that I wish I could read better than this. So we decided to blend this with the similar fabrication, in other words, restore, but with a stronger reading aid. And he was very happy binocularly because now he will be able to see reading as well. But we did warn him preoperatively, and that's very common. And generally, even with the monofocal, we tell them that there is a second eye syndrome and don't compare the previous eye, particularly on the experience with the operation table. They forget that they had a longer time, they forget that they had a pain and they could not see well immediately, but they want to do that in the second eye. So we do that extensively in every eye, but particularly in this eye, and he still would need selectively for some time. But luckily for him, the blending works very well, and binocular unaided performance was extremely happy, and he achieved what he wanted, as you can see there. So practical outcome was very satisfactory. Doesn't have any more glare because 2.5 really doesn't give that much when it drives at a distance. And only thing is being myopic with -1.5, his reading distance was different. And that's what we need to tell every myopic patient, that will happen. Even if you see well, your distance will be different. It won't be the same as you had with the natural myopia. So Be aware of you take a lot of chair time. And as I said, they are sometimes we feel it's not very reasonable, but they are not easy to please. And mentioned about their myopic advantages that they might lose to some extent. This is a very important case, and I want to share with our colleagues, those who are listening here. And the question asked is, what would you do? And there was a survey done on 90 plus or more than 90 ophthalmologists in US, and they asked, what lens would you prefer to have? And those surgeons who are putting more than 50 multifocal IOLs, those who put more than 50 IOLs, they selected 40% of them multifocal, but the rest, those who never put multifocal or less than 50, they went for quality. In other words, they went for monofocal IOLs. So that's the reality. With that background, this is the ophthalmologist of 60 years, still active, bilateral cataracts, and had progressive glasses in his life after the presbyopia. And as you can see here, the toric element as well in right and left. And he's a very busy practitioner, came from other states. Now, remember, we have to have a good crisp microscope vision and a slit lamp evaluation when we check the patients. And we go home, we don't have that, we are not MBAs or CEOs that we have a chauffeur-driven car. Most of us drive ourselves going home. And he was very keen because he had a good experience of his own patient, trifocal IOL. Luckily for him, his ocular profile optically was very suitable. We did discuss in detail at length, which we should discuss with everybody, that you will need some light more in certain conditions, in mesopic low light conditions. And you might see some halos, but if you're positive, it won't bother you and you will not register that very much. So we had binocular optic, panoptic toric lens at the interval of a month. We wait for 3 weeks always between the second eye. We want to see the refractive outcome. Is there any macular edema developing and so on. So we usually wait for 2 to 3 weeks before we operate the other eye. And he was very happy. And he keeps telling us now from where he is that he's able to examine, operate, drive, everything. And it's really not a big thing. So if you are motivated to compromise halos at times or use extra light at times or some reading aids at times, you can improve your lifestyle and consider the PanOptics lens at the time. Now, is the trifocal IOLs for everyone? What I learned from my experience and from my other colleagues at our hospital is that people who are doing a low light jobs, like if you have to drive a long driving in the night condition where there are no street lights, so like highways, and if you do the long one, or if you're doing in a factory or somewhere where it is low light, I would not consider PanOptics or any trifocals because they do need extra light, and it's not possible every time to have more light. I had a patient who was a marketing guy, and we put that multifocal lenses, and he was okay, but every time he visited different offices, the light condition was not ideal. He had to use his mobile light to have that. And he was really upset with that. The doctor, you didn't tell me that I'll need this extra light. So I think those who are working in a very, very low light conditions, I would caution you to consider any multifocal, including PanOptics lens. So that's something, but otherwise, you know, the PanOptics is very good. As I said, the halo is a trade-off, but it's not very much. And there is some lower contrast sensitivity, and therefore you must remember what I said earlier. And the real strength is that it has really as good a contrast sensitivity performance as monofocal in the average light condition. And the best part really is all the trifocals have that, but particularly in the real life from reading 40 to 60 centimeter to far, there is a seamless, continuous, good quality vision with this PanOptics because their intermediate vision now is at 60 centimeters. So most of us have the arm length and the working condition at that point. But other trifocal lenses also work quite well, but we find this one as disadvantage. And then these trifocals and PanOptics in particular really give us a great spectacle independence. So finally, pick the right patients, understand it, lifestyle and professional requirement. And luckily, we have a lot of options now. We have these group of lenses, the monovision strategy, the extended depth of focus, and we have one more new lens coming up. And without any financial interest, I know one for sure is from Alcon, a Vivity lens, which also is going to give us another option. I don't know yet very much about it, so I really can't talk. But so we have a lot of options now for our patients, and we can really perform this happy customizing for our patients. But mind you, you must spend a lot of chair time. I'm very happy to see Dr. Ramamurthy. So without any time, go ahead, because I know you have a course, and I'm going to your course now. So please, Dr. Ramamurthy, take over.
You'll need to stop share. Yeah, thanks.
Am I seen? Heard well?
Yes, sir. Yes, sir. Very well.
Thank you so much. I really appreciate this opportunity to be a part of this wonderful course. And the topic given to me is how I deal with my unhappy post-operative patients. I think I will exactly take off from where Dr. Abhay left, in the sense that about the chair time. And the time you spend preoperatively is most important. And the things we emphasize on to these patients is what we are aiming at is not doing away with glasses, but less dependence on glasses. Dysphotopsia is a small price to pay. They invariably, all multifocals come with that. Bilateral surgery is what will give you the best results. A touch-up procedure or an enhancement with a laser or some other device may be necessary to get optimal results. What you get initially may not be your final results. If you wait it out for 3 to 6 months, because of neural adaptation, the chances are that you are going to be much better off. And just in case, in spite of all the excellent counseling, excellent surgery, wonderful lens that you have put in, if the patient is dissatisfied with the ultimate outcome, these are the 5 C's that I deal with. And today, in the last half a decade or so, once I'm able to address this quite adequately, I find that labeling a patient as a crazy patient just because he or she is complaining, though your optometrist has noted down as 6 in 6 vision is wrong, very often they have a genuine complaint. And now we have the wherewithal to deal with it quite adequately. The most important reason for an unhappy patient is most often a residual refractive error. At the end of 3 months, if there is a residual error, I go ahead and do a transepithelial PRK or LASIK. It's more often a transepithelial PRK because it's smaller errors that you are dealing with. Once you do this, I find that it's not just the requirement for glasses that goes away, but the patients, even the dysphotopsia, the glare, halos, whatever difficulty they have, also goes away. Before that, of course, you have to make sure that the ocular surface is optimized, and that's not the reason for the complaints that the patient has, and it's genuinely the refractive error that is a problem. Just in case the refractive error is quite high, as in this case, came to me operated elsewhere almost 3 years back. It was a post-refractive surgery scenario, and the error was to the extent of about +6 diopters. So obviously, this is the explantation of the lens is out of question because I might disrupt the capsular bag. Already a YAC capsulotomy has been done. So the simple process of putting in a piggyback lens where the formula is that for each diopter of hyperopia, you require 1.5 diopters is a good way to go. And this gives you excellent results. But in case in the immediate post-operative period, you get a suboptimal results. Sometimes in spite of all the excellence in formulas that we have achieved, sometimes it does happen even today with refractive surgery patients. And today I have the confidence in some of my refractive surgery patients to even implant a multifocal or a toric intraocular lens. And if I find that the suboptimal result cannot be addressed with the laser or with time, then, and if the patient insists, and if I find a different kind of form of IOL power being suggested by the Barrett RX formula, I go ahead and do an Iol exchange. That's fairly easy to do. I wait for about a month's time. And even though it might be a hydrophobic acrylic implant, it's quite often to take out these lenses and exchange them just in case you have a suboptimal outcome. And in the case of toric intraocular lenses, if you have the residual cylinder that is left over, especially if the spherical equivalent of the residual error is almost zero, that's when the rotation of these lenses will help. And again, you can refer back to the manufacturers, or you could even resort to this, again, the toric Barrett RX formula, and that should give you exactly the degree to which it has to be rotated. I just go in with a infusion cannula, no viscoelastic is injected, and then optimally rotate the intraocular lens to its right position. And you owe it to your patients and yourself to get the best of results with these advanced technology lenses. And as far as posterior capsular pacification is concerned, obviously, if it's a thickening like this, none of us would hesitate to go ahead and do a yak capsulotomy. But if there is a multifocal intraocular lens in the eye, in case you get both eyes are the same patient implanted, you can see the left eye, there is some amount of diaphanous opacification. And obviously, even this can cause a significant deterioration, not just in the quality of vision, but also in the quantity of vision. Sometimes the patient is not happy, complains of a little haziness, can reach 6.6 or 6.6 parts. If you see this 3 to 4 months later, provided you have ruled out ocular surface problem, macular problems, and residual error problems, go ahead and do a yak capsulotomy for these eyes, and quite often you would end up with a satisfied patient. Decentration is something that's not talked about too often, but you can see 2 eyes of the same patient in this multifocal diffractive lens, and because of the rings, you can make out that the right eye is decentered and left eye is well-centered. And even if it's a monofocal lens, a decentration like this would introduce a significant amount of coma. And it's obviously sometimes it occurs because of inappropriate overlap of the rexus margin. And it's possible to laser hydroplasty has been suggested. I've done just in 2 patients, too much pigment dispersal. Generally, it's not very comfortable for the patient, but it's rotation of the lenses, which more often I do. And if at all, it's possible to recenter the lenses by rotating them. Negative dysphotopsia is a complaint that some of our very well-done patients do. This is actually a lawyer who was operated by a dear friend of mine. A toric intraocular lens has been placed, and excellent 6.6 refractive outcome. The patient was extremely disturbed by the negative dysphotopsia, and my friend just referred the case to me. And because of it was a toric lens, I did not want to bring it out of the capsular bag, did not want to upset the a very optimal refractive outcome that has been achieved. So went ahead and implanted this piggyback lens with a 0 power in it. And because it has a rounded edge and the square edge of the primary lens has been masked by this lens, almost immediately the dysphotopsia did go away with. You could, of course, do a yak capsulotomy for the edge of the lens also, but I prefer to do this in this case. There have been 3 other cases where I have done with excellent results. So this is one way of dealing with a negative dysphotopsia. And in this situation, you can see the 2 lenses, the primary lens and the secondary lens, both on the slit lamp and on the anterior segment OCT. Do not underestimate the problem of this dryness, ocular surface problem. This lady is going to tell the whole world that she's not comfortable with the surgery, might have an extremely deleterious impact on your surgery. So not just after surgery, but before surgery, even before your optometry, you have to optimize your ocular surface. Just in case it has not happened, the patient is having fluctuating vision, photophobia, fatigue, increased mucous matter, etc. It could be ocular surface problem, and there are various ways of dealing with it. I'm not going to go into it, but then dealing with it is something that's extremely important. And again, post-operatively, I believe less is more. This is the exact prescription that we give to our patients, the printout of the prescription. That's the reason that, I'm sorry, the names are mentioned over there, but any equivalent medicines would do well. It's essentially steroid antibiotic just for a period of 2 weeks. NSAIDs continued for 6 weeks, and a lot of carboxymethyl eye drops. And I find that with this regimen, minimalistic application of eye drops with a lot of lubricants, you very often get an optimal outcome. An epiretinal membrane can be as high as 6% in some of our patients. And these are the kind of diseases which our our cataract patients can have, which can have a negative impact as far as the visual outcome is concerned. And these can easily be missed by essentially an anterior segment surgeon. That is the reason, not just for our premium intraocular lens patients, for every patient, we go ahead and do a preoperative OCT. And just in case postoperatively the visual outcome is suboptimal, especially after a reasonably good visual outcome in the earlier period, this could very often be a CME. A retinal consult is necessary. It could be a diabetic maculopathy which has worsened, and appropriate addressing those problems is extremely important. And quite often, the patient comes in saying that I'm very happy with my quality of vision, but then dysphotopsia, a little bit of difficulty in night driving is a problem. I have this simple -2 diopter lenses. I put these lenses onto the patient and tell him, go ahead and try to read now. Yes, you have a little bit of dysphotopsia, but that's a small price that you pay for total spectacle independence. If you want, I can exchange these lenses and give you back a lens which might reduce your dysphotopsia, but then you will end up wearing glasses for reading. Mind you, once I do this, most often the patient says, yeah, dysphotopsia is not much of a problem. I would rather live without glasses, and decides to stay away from any active intervention. I'll just take you through a few case scenarios. You can see over here, I had done a LRCS with a Symphony multifocal intraocular lens. This is essentially to drive home the point. The second eye surgery is a great tool for addressing some of the refractive issues or some of the initial problems that the patient had. Symphony is a great lens, but it's somewhat deficient for near vision. Patient required +1 diopter as far as near vision is concerned. Was not very happy with that. So we actually put in a Technis +4 diopter in the other eye. Bilaterally implanted, the patient was quite happy. Going on to another scenario where this patient just required a +0.5 diopters as far as near vision was concerned. And can it take about a minute and a half, Shay?
Of course, sir. Of course, sir. As long as you want, sir.
Okay. Just about a minute. +0.5 diopters in the other eye. In this case, what exactly we did was did not change the type of the lens, but put in the same Symphony toric lens with LRCS in the fellow eye, aiming at a target of -0.75. So bilaterally implanted, these patients ended up doing well as far as the ultimate visual outcome is concerned. And that's one of the reasons we always allow at least 2 weeks between the surgery, minimum of 2 weeks between the surgery between the two eyes, and titrate the power in the second eye, titrate the type of lens that we implant depending on the outcome in the first eye. Looking at this case, this was a case which had a significant cylinder, underwent a LRCS with a Symphony toric. The patient was extremely happy with the distant vision outcome, but again, the problem that the near vision was not quite sufficient, required a +1 diopter rad. So what we essentially did was went ahead and did a panoptic toric in the fellow eye. So once we implanted the trifocal toric, which definitely has a greater capability as far as near vision is concerned, bilaterally implanted, this patient was happy. So mix and match, monovision, etc. has great concepts, and it's only limited by your imagination, the patient's requirements as to how you apply them. This is the ultimate results that we got, so that bilaterally implanted near vision also became a possibility. I think neuroadaptation is both the problem as well as the solution. And it is difficult for us to predict as to which patient is going to neuroadapt and which patient is not going to. So when the patient presents to you with initial complaints, be encouraging to them. Tell them that just like learning cycling, you have to get used to these lenses. Give it about 3 to 4 months. Once you have ruled out that none of the other problems that I alluded to earlier are not there, allow some time, counsel patients, and ultimately you find that majority of the problems that the patients came to you does go away. This is my ultimate slide. This is my final slide and my most important slide. And I think when a patient comes to you with a complaint, it's most often an observation. It's not, they have not come to fight with you. And neither should you become aggressive and say, after all, I counseled you about dysphotopsia earlier. Why the hell are you coming back to me? Just learn to live with it. My approach is that tell them, I understand your problem. If you're having glare and halos, that means the lenses are working very well in your eyes. Just give it some time and the problem is going to go away. The patients essentially want to know that you care for them, that you understand their problem, you're concerned about them, and you have the confidence to deal with it. And once you give them that confidence, most often your post-operative outcomes, irrespective of whether it's a premium intraocular lens or not, does go away. Thank you so much for your kind attention.
Thank you very much, sir, for the amazing talk and plethora of several cases. I had, sir, just one observation that the dysphotopsias, when the trifocals came in, we were actually more wary that adding another focus is likely going to make things worse. Surprisingly, in our practice, we have found the complaints of dysphotopsia have actually reduced after trifocals compared to the traditional multifocals. Do you feel the same as well, sir?
Absolutely, absolutely. And I feel there is a reason for it in the sense that, most of the conventional multifocal use about 82% of light. And it is the light which is lost to diffraction, the 18% which causes the a dysphotopsia. While in a case like the panoptics, it's almost 88% of the light is used up. So there is less light available, which is causing a problem. And much of the light gets redistributed to the intermediate focus. I think that's one of the reasons for the dysphotopsia being less. I definitely had these concerns with me also, just as you mentioned. But in real life practice, we find that the trifocal patients have less of this complaint.
And I think, sir, I've heard you before talking that it's very important to keep no threshold for astigmatism correction, particularly for trifocals. So, sir, would you highlight what is the cutoff or anything that you use as a benchmark?
I would not put a single figure on it, and I think it's extremely important whether it's against the rule astigmatism or with the rule astigmatism. Basically, I'm sure you're doing it in your practice. Any patient who is willing for cataract surgery, the first thing we do is to put the patient on the optical biometer and use the Barrett toric calculator formula. And in case that shows up that the patient needs a T2, even then we suggest that it might be a good idea for you to go for a toric multifocal or a toric trifocal. Because we have found that the patient has been counseled before, accepted a trifocal, and then you find there is a significant cylinder which is not there in the glasses. But because the posterior corneal astigmatism, other factors, it shows up on the calculator, then you have to recounsel them. So for me, if it is against the rule astigmatism, even if it's 0.75 diopters, especially with a multifocal, I would address it. Maybe with the rule, I'd go ahead, extend it up to 1.25 diopters. But then if the calculator shows that the patient needs a toric correction, then definitely we enter into a conversation with the patient about these lenses.
Thank you very much, sir. Thank you.
I think there are a couple of patients, just to add on, there are a couple of patients where, you would either go with a monofocal, and if they choose a monofocal, I would counsel them for a monofocal. But the moment they choose a multifocal, I counsel them for IQ or a monofocal versus a pantoric. Because when you're looking at clearing up, all ranges, that small astigmatism should not become a deterrent. So I think that was a great point you brought up.
And what I learned from Dr. Ramamurthy many years ago, that astigmatic defocus is more degrading than the equivalent spherical defocus. So astigmatism is the now game, whatever you're doing, multifocal or whatever. Astigmatism correction should be a routine. Toric IOL, I think, it should be a default for everything, if there is anything, as Dr. Ramamurthy highlighted very well. So thank you.
Thank you.
But DR, I just want to tell you, this swap over, those who, we had a conflict, and I went to Dr. Ramamurthy's course and he's here. It was so smooth. I mean, running around physically from one hall to another, this is so easy. I wish we had the same arrangement, because it took a minute, and Chitra was so kind. I just appeared on the screen and I started talking. So that was terrific.
Great.
Very good.
Wonderful.
Okay.
Thank you so much for the opportunity. I really enjoyed being here. Thank you very much.
Thank you. Okay. Now we move on to the next presentation, which is, I think, may find a little intimidating seeing this complicated pictures and machine, but I think it's important, and Shail will dwell in it now.
So I think when we at the outset, I do acknowledge we received research grant support from Alcon Laboratories, and I acknowledge the contribution of our colleagues at Raghudev Eye Hospital in making this presentation. So whenever, right now we are doing all of this virtually, but whenever we visit any conference and go to the trade area, there are zillions and zillions of newer equipments that have come up, and each equipment is supposed to be the best in the world and something that you cannot do without in your practice, and is going to be the next big thing. So are all of these so many fancy equipments really needed? Is it a necessity? Is it a fad? What is it? So let's go through one or two of cases to identify which investigations are more useful than others. So this was a kindergarten teacher, 45 years of age. She's been a myope since a very young age and contact lens user, and now finds it difficulty in tolerating contact lenses, and came to us for an opinion of clear lens extraction because she's never worn glasses all her life, and she likes to be seen without glasses. And now, because she's not able to tolerate contact lenses, she's having to wear glasses. Now, when we evaluated her, we found that there was the tear film evaluation showed an extremely high breakup time. I mean, very fast breakup time. And the eye trace showed bizarre corneal aberrations. So we decided that we are not going to even talk about any form of surgery as of now. This is the corneal aberration profile of the patient without any treatment. And we told her that we need to treat your ocular surface first before even discussing possibility of any form of surgery to reduce dependence on your glasses. So after 3 months, the patient improved her aberration profile. She has negligible astigmatism, and she became a candidate for refractive lens exchange. So this is the same patient pre-treatment with a poor ocular surface. And look how almost all of the ocular surface aberrations have gone just by treating the ocular surface appropriately. So I think dry eye assessment is often underlooked or is laughed upon at, but is one of the most important factors in deciding the post-operative happiness of the patient, because not only are the symptoms going to bother, but like Dr. Samresh very correctly showed, your measurements are also going to be inaccurate with a bad tear film. There are several tear film measuring devices and tear film osmolarity marking and so many different instruments. We have limited experience with this tear film analyzer IDRA, which is I think sold by My Healthscape in India, and it gives us lot of information regarding the tear film. So this report is showing us just the tear film meniscus height. It comes with normative values also, but also you can look at the raw images and look at the actual tear film height. You can look at the tear film breakup time, and if you find that the tear film is breaking up very quickly, it will show up on these spots. If these spots are too many red spots, that means this is breaking up too quickly. And you can also get meibography to actually identify the cause of this poor ocular surface, because each requires a different form of treatment. So these investigative devices are definitely helpful. They are not a necessity in day-to-day practice, but at least it definitely helps in patient education. So if the patient has certain symptoms, we can show it to them that, look, this is the cause, and therefore we are suggesting X, Y, or Z treatment, or therefore we are not suggesting a multifocal IOL for you. There are tear film analysis devices like MMP9 markers, which give, if they are positive, suggest an inflammatory cause for the tear film. But like I said, the role in a day-to-day clinical practice is probably limited, and I wouldn't say they are the #1 investigations which you should invest on for premium practice. I think this is one investigation which all of us should be looking as a basic now in our practice. That is the optical biometer. And optical biometry has evolved tremendously over the last decade and a half. And the newer optical biometers, what they call as the swept source based biometers, is nothing but Fourier domain OCT based biometers. And the reason why they are going to be the future is because they have a very high penetration rate even in the densest of cataracts, which is more relevant to our part of the population than, say, in the Western population. And we did our own study where we compared Lenstar versus the Tomy swept source OCT, which we have access to both of them. And we found that while in the Lenstar, we were able to achieve axial length in 84% eyes, we were able to achieve axial length readings in almost 98% of eyes with the swept source OCT, which means except for those extreme wide cataracts, it penetrates through almost everything. And that improves your IOL prediction, your calculation, your post-operative outcomes. And this is what we published last year, the same data showing that about 1/5 of patients, almost 20%, could not be captured on the Lenstar. This is another case. The patient came to us for a second opinion, complaining of glare. Very well done cataract surgery elsewhere, full diffractive multifocal IOL, retina is normal, OCT is normal, everyone has seen him and everything is perfect. But when we did his eye trace, we found that there are a lot of unexplained aberrations internally, and there was no PCO. It's a crystal clear posterior capsule. So if there is significant astigmatism, we can understand, but all of these were not adding up as to why this patient is having so many ocular or dysphotopic phenomenon when everything else seems to be good. When we looked at it, we found that his angle alpha was quite high, which means that the rays, the centration of the IOL was such that the rays of light were actually passing through the rings of the IOL. So in spite of a perfect, refractive outcome, the patient had a poor quality of vision because his angle alpha was quite high. So what is the role of angle alpha for a cataract surgeon, and how can we evaluate it? And I think I acknowledge the contribution of Samresh present in making and explaining these slides to us, that the IOL basically sits in the center of the capsular bag. Now, there's no way we can measure the center of the capsular bag. So therefore, we sort of use a surrogate measure as the center of the limbus, whereas the light is actually going to pass through the visual axis. So when the difference between both of them is very high, the light rays are going to pass through the rings of the multifocal IOL rather than the central zone, which is the clear zone. And therefore, these patients have photic phenomenon more compared to others, in spite of everything else being normal, perfect biometry and everything else. So any angle alpha more than 0.5, you should keep a close eye on that. The only positive part with the newer trifocal generation of IOLs is, particularly with the PanOptics, and I'm sure the others coming up will do the same, is that it has a larger central bullseye, which means it is more forgiving for angle alpha. With the traditional multifocals, we were more fastidious and we had a cutoff of 0.4 actually before the trifocals came in. Now we are a little more liberal and go up to 0.5 or 0.6, but anything beyond that, be cautious that this is the patient who's going to complain of the photic phenomenon. I think, as has been highlighted very beautifully by Dr. Ramamurthy, that OCT evaluation is now becoming more and more mandatory. So this is a fundus photo image of a grade 2 cataract, which we're planning for cataract surgery. Absolutely nothing in the fundus, healthy disc, now normal looking fovea. And when we did the OCT, we found that there was an epiretinal membrane. So this was missed not just by the cataract surgeon, but also by a trained retinal surgeon who had seen this patient multiple times before, including in the preoperative time. So I think macular pathology is something that is the biggest bugbear for post-operative poor quality of vision, irrespective of monofocal or multifocal IOL. And we did our study evaluating all the preoperative patients we do as a routine in our practice. We make them undergo posterior segment OCT. And the patients were clinically evaluated by retinal surgeons, and even the OCT was evaluated by the retinal surgeons. So the first important observation that we found in our study was that a reliable OCT scan could be achieved in 95% of eyes. So even in very dense cataracts, in most cases, you are able to get a good signal strength enough to get a reasonable scan. And macular pathology was identified in 18% of eyes, where it was labeled as normal retina, normal fundus, normal fovea by the retinal surgeon himself. And the most common pathologies that were found were ERM, RP irregularities, and then foveal atrophy, vitreomacular traction, so on and so forth. Another clinical example of a seemingly apparently normal looking fundus but had vitreomacular traction or a lamellar macular hole on OCT examination. And this is something, this is by the article that we published regarding the role of OCT and subtle pathologies detected on OCT when screened clinically by all cataract and retinal surgeons. So I think these are some of the newer investigations which I think sooner or later are going to become a part and parcel of our cataract workup. And I think if I have to highlight two, optical biometry, particularly the newer generation swept source based OCT based biometers and posterior segment OCT are, I think, going to become a norm as far as routine preoperative cataract workup goes, and they help us not only to raise the bar, but improve the predictability and precision with which we operate, and therefore less pre-operative chair time counseling them about unpredictable visual outcomes post-operatively. So thank you so much once again for the patient listening.
I think what I understood, as a practitioner, say for example, I don't have many equipments. I have a keratometer, a topography, and a posterior segment OCT. Now I want to raise my bar, as you said. What is the next one that I should have, which will help me to increase my premium IOL practice?
I think the number one tool that I would suggest is a good optical biometer for two reasons. One is it not only does it help in improving axial length measurements, but most of the stalwarts who have given us all of these toric IOL formulas and who teach us about toric IOLs also believe that the keratometry of the newer generation optical biometers are the most reliable as far as toric IOL calculation goes. So it gives us two major advantages. One is reliable axial length readings, as well as reliable keratometry readings, which can be used directly from the optical biometer into the calculator. All of them also now come up with all of these formulas inbuilt into their systems. So there's less amount of hard work that is required, and all of these things come out in your regular printout sheet. So I would suggest the number one tool for upgradation into practice first would be the optical biometry. Second would be the OCT evaluation, and third would be corneal investigative tool, because deciding regularity of astigmatism is important, and I think corneal investigations do help in that. But the subset of patients having gross corneal irregularity, which get missed otherwise, are quite low. So optical biometry and OCT would be number one and number two as far as I would go. You're muted. You're muted.
The difference between optical biometer and swept source, one is that the penetration is more. But is there any other difference? Wherever we can with optical, is it as sensitive or as good as the swept source? Why should I spend more money on a swept source?
So I think that's a very good question. Two things. What we showed in our publication, as well as there are several publications comparing the older generation biometers versus the swept source. One is that they are interchangeable. So if they are non-inferior as far as the measurements go. So swept source measurements are as reliable or as good as the older generation biometers. The second major advantage is that we get a lot of patients with posterior subcapsular cataracts. And many of them, we need to do ultrasound immersion biometry, which is not only cumbersome, but is more technician dependent. And the third advantage with most of these newer generation swept sources, that quite a few of them have come up with ways to measure the posterior cornea also along with them. And they also do give us measurements of the angle alpha and angle kappa as a part of biometry measurements. So reliable. So you need lesser, you'll need lesser dependence on other equipments if you have a good swept source based biometer with you in your practice.
Okay. Samresh, what about, should we have an aberrometer? Because I keep seeing these photographs of traces and other things. Where will you position the value of aberrometry if I want to do a premium IOL practice?
So again, in the context of prioritizing, it's probably the last in the priority listing. I think if we could have it, everybody should have an aberrometer. But with the price that it comes at, the basic knowledge of aberrometry is more than important. You don't really need to run an aberrometry scan for all patients. So if you have a patient that's coming to you which is post-LASIK or post-traumatic with a scar or something which is not out of the ordinary, you could refer to get an aberrometry scan done. But for most patients, the basics are still the basics. You have to, if your cornea is regular and the patient has a pristine virgin eye, it's unlikely to have an aberrometric disturbance for generalized. So while aberrometry holds very good for institutions and practices that are handling more and more post-LASIK, post-RKIs or complicated cataracts, For a regular practitioner, I wouldn't rate it too high in terms of priority listing for purchase in the beginning.
Okay. Lajja, in your
Yeah.
opinion, which are the number 1, 2, or whatever 1, 2 equipment that you would put it on a higher up on the list?
So I would say that if somebody couldn't really buy a swept source keratometer or optical biometer, then some access to topography is very important, because given that the astigmatism incidence is extremely high in our population in cataract undergoing surgery patients, if you have an access to something that tells you the regularity of the astigmatism that you're dealing with, again, that would be a very important tool to have. But again, it's not a very, very common thing to have a very irregular astigmatism. So if we had a choice, if you could add something to your existent armamentarium, I would suggest something that would also give you a tool that will give you the topography of the corneal profile.
Yeah. So just adding on to that, I think in today's market, topography does much more than just look at the astigmatism. So, you know, it's a very big value-added tool, because you can do dry eye analytics with most current topographies, and that can be a parallel revenue source, can help you get the, you know, recover your investment back also. So you can, you know, you can run a parallel dry eye practice with just a good topographer, because mebography and tear film breakup time and tear film height will now come as a standard with good topography machines.
And even that can give you a lot of aberration profile too. A good topographer can do that also.
A placido topography can give you corneal aberration profile. Aberrometry will give you profile of the internal surface of the eye, but a topography is good enough to give you corneal aberration profile. That's a great point you brought up.
I just want to give a different perspective. And you mentioned the revenue part of these, whatever we are doing, and there's a catch here. We all want to increase our premium IOL practice, toric and multifocal and whatever else. Not to really make more money by increasing the fees for these particular lenses, but primarily we must never forget that we are doing it to really improve the lifestyle of that patient. Many of them are knowledgeable and they will ask for that particular technology IOL, but even if they don't, it's our duty to tell them that if you have this particular IOL and you are suitable, otherwise you will have a much better quality of your life and vision both. So you may consider it. So we do not want to hesitate to forthrightly suggest them. Don't feel guilty that patient or the population in your practice might feel that you're charging more. Do not be worried about that aspect, because you're doing it with the sole objective or the main objective of improving the patient's lifestyle and giving them a quality vision. So that we should never forget.
So just for clarification, I think you brought about a great point. What I meant to say was topography.
No, I don't mean you said that, but
no, what I mean is, what I'm just wanting to bring about is the fact that, you know, it adds value in the terms that not only as a cataract practitioner, you can run an independent dry eye clinic with the available options to you right now, which can add value to the clinical practice generally.
So I want one final comment from each of you, Lajja, on this whole course of these facing these confusing and difficult situations. 1, 2 lines.
So one thing I would say is that talking about everything that we are doing is extremely important.
Okay.
No matter how uneducated, we can always reduce science to a very lucid term that the patient can understand. So talking about everything and enrolling the patient in what we are trying to do, I think is a very important tool in overall success of our practice today.
Thank you. Samresh, 1 or 2 lines.
I think
you have only less than 2 minutes.
In extension of Dr. Lajja, talking and involving the patient in decision making by showing them diagnostics will go a long way.
Say.
I think getting used to or getting adapted to using online formulas, the newer formulas, is a resistance that most are facing. They like to use only whatever is there in the machine. So get used to using online good formulas, and because they are free and easy to access. And second is, I think trifocals are probably the sort of game changer as far as I feel, as far as the IOL technology, at least that I see in the foreseeable time to come.
For me, I think toric, correcting the astigmatic defocus, toric component of the IOL remains very foundational, fundamental. And if you can build up on that the lifestyle issues of multifocality and panoptics is helping us a lot. Our practice of percentage of multifocals has increased once the panoptics was in our hands. So I think these are the things that we learned over the years. So thank you so very much for your patient hearing, and thank you all. Goodbye.